Hi everyone. Today we will discuss the third part of carcinoma larynx, that is staging. Okay, so this is a small topic, but a little bit of a, I would say, a little bit of a complicated, not so complicated, little bit complicated topic where we are going to discuss slowly and try to make it as simple and easy for you uh, to understand the concept, but at the same time able to write it in the exam. So what is TNM staging stands for? T stands for tumor size and extent. So tumor size and extent. Okay, extent means where is it growing, going into, from where it is going to which part. N stands for spread of the cancer to nearby lymph nodes. So just as a recap, supraglottic cancers will go into the upper deep cervical and middle deep cervical lymph nodes. Glottic carcinoma, there is no lymphatic spread, and subglottic cancers will spread into the lower deep cervical lymph nodes and mediastinal lymph nodes, either directly or through pretracheal, paratracheal, and prelaryngeal lymph nodes. Okay. Now, M stands for metastasis. Metastasis, it is going beyond the lymph nodes, so into lungs, liver is the most common, or into the vertebrae also it can go. Okay. So these are the metastasis. T stands for tumor size and extent. N stands for the spread of the cancer to the lymph nodes. M stands for metastasis. So this is the table which basically gives you everything about T. Tumor size, T1. So there are T1, T2, T3, T4 is divided into T4A and T4B. So there are 5. 1, 2, 3, 4, 5. So what is T1? T1 when the tumor is limited to one subsite only. Now, as we can remember from the previous discussion, the first discussion of anatomy, the supraglottis, there are components, right? There is epiglottis, there is array epiglottic folds, there are arytenoids, there is false cords and ventricles. So these are the 5 subsites. Okay, these are the 5 subsides of the site called supraglottis. Glottis has 3 subsides: anterior commissure, posterior commissure, and the vocal cords. Anterior commissure, posterior commissure, vocal cords. And subglottis is there are no components. So these are the various subsides. Okay, so if it is limited to one subside, suppose the growth has started in the epiglottis and it stayed in the epiglottis, then it comes under T1. T2 when it is extending to adjacent sites or subsides, adjacent subsides and sites. Okay, so suppose there is a growth of the vocal cord. Okay, suppose there is a growth of the vocal cord, and from the vocal cord it has gone on to the false cord. So it has crossed the site. It has gone from the glottis to the supraglottis. So this is also stage T2 only. Okay, but now we are adding one component. As long as the vocal cord mobility is normal, this one will apply. As if it is limited to one subsite and there is impaired vocal cord mobility, it comes under stage T2. So with the impaired cord mobility, whatever may be the extent of the tumor, it comes under T2. So impaired vocal cord mobility is very important. Okay, so that's why in indirect laryngoscopy it's very important to see whether the vocal cord mobility is normal, impaired, or fixed. T3 now he's not at all talking anything about the extension of the tumor. He's directly talking about the vocal cord fixation. Once the vocal cord is fixed, it is stage T3. That's all. And this is the most common way the presentation happens, and this is most of the questions in your NEET PG also will come that the vocal cord is fixed. Now what you want to do? Something like that. Okay, so vocal cord fixity means stage T3. This is something that I want you to remember. Vocal cord fixed means T3. Vocal cord mobility is impaired means T2. Vocal cord mobility is normal means T1. So I saw a patient. He was a teacher. He was a non-smoker. He came to me with a T1 carcinoma, maybe 8-9 years back. Vocal cord mobility was perfectly normal. There was an ulceroproliferative growth. The moment you see it, you look, something in you tells you that it is carcinoma. Okay, the way you look at it, the number of cases you have seen, he's a non-smoker, it should not be carcinoma, but it was carcinoma. He underwent radiotherapy. That was 8-9 years back. So he still comes to me once in a while for checkup, and he's absolutely normal. The success rate, the prognostic success rate for T1 carcinoma is super. Like, they will almost lead a normal life. Okay, so that's why it's very important for you to remember that T1 is normal cord mobility, T2 is impaired cord mobility, T3 is vocal cord is fixed. Now there is another thing, if it is spreading or extension beyond the larynx. Now all these structures that we talked about, supraglottis is the epiglottis, epiglottic folds, arytenoids, false cords, vocal cords, ventricle, and this is anterior commissure, posterior commissure, and ventricle, and subglottis. Do you observe that all these parts, all these form the larynx? This is what larynx is made up of. These are various parts, sides and subsides of the larynx. But pre-epiglottic space, post-cricoid area do not come under the larynx proper. So that is, once you say that the tumor has gone into the pre-epiglottic space or the paraglottic space, both are communicating, right? Pre-epiglottic space is communicating with the paraglottic space. Once it goes into that, it is stage T3. That is very important. Spread of the tumor beyond the larynx, but it is just beside the larynx. It is not extending beyond much space, just a little bit away from the larynx, but it has lost, it has gone beyond the confines of the larynx, what we call the larynx proper, and it has gone into the pre-epiglottic space or the post-cricoid area. Post-cricoid area, it is just posterior to the posterior commissure, but once it goes into the post-cricoid area, that means that it is stage T3. That is stage T3. Okay. Now stage T4A. Now we are not talking about vocal cord fixity. We are not talking about extent of the tumor. Now we are talking about extending beyond the larynx. Now, if it is invaded through the thyroid cartilage and tissues beyond larynx. This is your larynx, okay? So these are the epiglottis, vocal cords, and this is your thyroid cartilage, right? So it is quite far away. It is quite far away. So thyroid cartilage is here, and there is a pre-epiglottic space and a para-epiglottic space here. So it is going beyond the larynx into the pre-epiglottic space, paraglottic space, post-cricoid area. Still we are putting it in under T3. Once it is touching or it is invading the thyroid cartilage, we have some photographs. We'll be describing them again. So once it is invading the thyroid cartilage, either partially or through the thyroid cartilage, it comes in the stage T4A. It is going T4. It is becoming T4. Once the tumor is invading thyroid cartilage invasion is as important a word as vocal cord fixation. Vocal cord fixed means it is T3. Thyroid cartilage invasion means stage T4A. Okay. And also if the tissues beyond the larynx locally. What are the tissues beyond the larynx locally? Trachea, tongue muscles, strap muscles, and esophagus. This is also, it has gone beyond the larynx and it is extending into the upwards, downwards. It is invading the trachea. It is invading the esophagus. In front, it is invading the strap muscles of the neck. Anterior superiorly, it is going into the muscles of the neck. Muscles of the tongue. So all this also comes under stage T4A only. T4A only. Then what is stage T4B? Stage T4B, distant metastasis, distant places away from the larynx, beyond the larynx, distant spaces like prevertebral space, mediastinum, carotid. It is sheathing the carotid. So now beyond the larynx into prevertebral space, mediastinum and carotid. Now coming to, again we'll be describing the T staging with diagrams. So T staging, T1, tumor limited to one subside of either the glottis, supraglottis or subglottis. It appears like this. So this is the vocal cord, right? On the vocal cord there is a growth on the free edge and the upper border of the vocal cord. It is not invading into the false cord. It is not invading into the anterior commissure. It is not invading into the posterior commissure. There is only one subside of the glottis, only. So it comes under stage stage T1, and there is no problem with vocal cord mobility. The vocal cord mobility is normal. Okay, now coming to stage T2. Stage T2, tumor extending to adjacent subsides or sides. So here there is a tumor that is started in the vocal cord and it has gone into the false cord. So there are two sides involved, two sides. Glottis is involved and supraglottis is involved, or it can be a tumor from the epiglottis going onto the false cord, or it can be a false cord going into the arytenoid, or it can be a false cord growing into the aryepiglottic fold. All these, if there are more than one subsite, adjacent subsite, then it comes under stage T2. But that if there is impaired cord mobility, what did we say? Impaired cord mobility, it means that the vocal cord is not moving as normal. You can always compare it with, this is the left side, right? Left side vocal cord is not moving as well as the right vocal cord, which means that there is impairment of the vocal cord mobility. Impairment of the vocal cord mobility, stage T2. As the tumor is growing, the T is also growing, right? Stage T3. T3 means vocal cord fixation. T3 means vocal cord fixation. T3 means vocal cord fixation. I want you to remember it. Okay. Otherwise, it is also like it is going beyond the epiglottis and into the paraglottic area, into the pre-epiglottic area or the paraglottic area. It is growing into the pre-epiglottic paraglottic area. It comes under stage T3. Also post-cricoid area. Post-cricoid area, if there is a tumor of the vocal cord, it is growing here, and it's also growing into the post-cricoid area. Then you will see some pooling of saliva also in such cases. Patient will also have dysphagia in such cases, okay, along with hoarseness of voice, and also pain to the neck sometimes, maybe. So here the vocal cord mobility is gone. So we denote it by one line. Vocal cord mobility is gone. Vocal cord mobility. Vocal cord is fixed. It absolutely, there is no movement of the vocal cord. Vocal cord, the right vocal cord is moving normally, but the left vocal cord is not at all moving. Then vocal cord fixation. Either it is extending into the pre-epiglottic or the paraglottic area, and the post-cricoid area, you come under stage T3. Causes of vocal cord fixation, we already talked about it. If there is a thyroarytenoid muscle, it goes into there is infiltration, causes vocal cord fixation or impaired vocal cord mobility. Cricoarytenoid joint fixation, any recurrent laryngeal nerve invasion also can cause vocal cord fixation. Stage T4B. Now this is, I want you to remember this. This is the thyroid cartilage. This is the thyroid cartilage. Okay. Suppose it is extending a little bit into thyroid cartilage, it comes under stage T4A. It is extending beyond the thyroid cartilage, from inside it is crossing the thyroid and going outside, it's stage T4A. Okay. So any thyroid cartilage invasion, it comes under stage T4A. Any thyroid cartilage invasion, it comes under stage T4A. You have to remember this. T4A means thyroid cartilage invasion. Thyroid cartilage invasion means T4A. Tissues beyond larynx, locally we talked about it. It can go into the trachea, adjacent areas now. Esophagus, it goes into esophagus. It goes into trap muscles. It goes into the neck, tongue muscles. All these are local areas, which is very close to the larynx. Also comes under stage T4A. So stage T2, it is confined to the larynx. Stage 3, it is going beyond the larynx into pre-epiglottic. Stage 4A, it is going beyond the thyroid cartilage. Stage T4B is distant places. Tumor is extending beyond the larynx to distant places, like it is going into the prevertebral space. Okay, prevertebral space, mediastinum, it goes into the mediastinum, and there's a carotid, there is the encasing of the carotid sheath. So it is going into the mediastinum, and it is going into the important and deep structures of the neck. At this stage, you cannot operate on such cases. Okay, so prevertebral space, mediastinum and carotid, once it is going beyond the distant spaces, it comes under stage T4B. Okay. Now, coming to end staging. End staging means neck nodes, right? N0 means there is no cervical metastasis. M stands for distant metastasis. M0 means no metastasis. M1 means metastasis is present. Now, N1. This end staging, you just remember this. Remember this letter, this number, equal to, less than or equal to 3 centimeter. 3 centimeter, if you can remember, then you will mostly come to understand the various parts of N1, N2, N3. N1, it is 3 centimeters, equal to or less than 3 centimeters. N2, it is greater than 3 centimeter but less than 6 centimeter. As long as it is less than 6 centimeter, it is N2. Once it is greater than or equal to 6 centimeter, it is N3. Okay, so 3 centimeter N1, 3 to 6 centimeter, 3 greater than 3 but less than 6. You cannot say 3 to 6 because 3 comes under N1, 3.1 comes under N2, right? Greater than 3 but less than 6. 6.1 greater than 6.1 is N3. Now coming to N1, here the disease is single. There is only a single lymph node and ipsilateral on the same side of the lesion, and it is less than 3 centimeters. So these three things have to come together: single lymph node, Same side of the lesion less than or equal to 3 centimeter, it is N1. Once this 3 combination is crossed, like suppose it becomes multiple, suppose it becomes contralateral, suppose it becomes bilateral, it goes to N2. Okay, so what did we understand? What did we say from the beginning? 3 centimeter, 3 to 6 centimeter, greater than 6 centimeter, greater than 3 to less than 6. Okay, so in addition to this numbers, if it is single and ipsilateral, it is N1, multiple, contralateral, bilateral, then N2. Anything about 3 centimeter, anything above 3 centimeter directly goes into N2. Anything less than 3 centimeter goes into N1. Okay. Whatever it is, it can be single or multiple. Once it is greater than 6 centimeter, it is N3. So you may have a single lymph node, but it is greater than 6 centimeter. Then it comes into N3. Suppose it is 3 centimeter. So suppose, just to draw, make it more easy for you. This is the larynx. Okay. So there is a single ipsilateral lymph node less than 3 centimeter. So this is N1. Okay. So suppose this is a 5 centimeter lymph node. It is single and it is less than 6 centimeter, N2. Suppose it is ipsilateral lymph node, it is both of them are 1 centimeter. Okay, but there is multiple. Once it becomes multiple, it becomes N2. Okay, suppose this is the right side, there is a lesion, but you have a contralateral lymph node. This is very less, like 1 centimeter. Then it becomes N2. Whether it is single, multiple, unilateral, bilateral, contralateral, whatever it is, greater than 6 centimeter, big lymph nodes. Okay, greater than 6 centimeter, it is N3. Okay, this is how you can remember M staging. M staging we already talked about. M0 means no distant metastasis. M1 means there is distant metastasis. Now coming to the staging, this is also a bit complicated. There are 6 parts I want you to remember. Stage 1, Stage 2, Stage 3. Stage 4 is having 3, Stage 4A, Stage 4B and Stage 4C. So there are 6. The first 2 is easy, last one is easy. Okay, so Stage 1 is T1, N0, M0. Stage 2 is T2. So T1 means Stage 1. If the tumor is in T1, that is limited to one subsite. T2 limited to going from one subsite to another subsite, or impaired vocal cord mobility, comes under stage T2. Okay, T1 is stage 1, T2 means stage 2. Any M, stage 4C, this is also easy. Any once metastasis, it comes under stage 4C. Okay, stage 4C. So once there is metastasis, it comes under stage 4C. Now, this stage 3, stage 4A, stage 4B. Just remember N1, N2, N3. Okay. So stage 1, stage 2, N0. From there comes stage 3, N1. N1 is stage 3. N1 is stage 3. N1 is stage 3. Remember this. N1 is stage 3. N1 is stage 3. Whatever may be the T. Okay. So T3 is also, so there are 2 now. T3 is also stage 3. T4A. T4A, what did we say? Local spread beyond. That is, T4A is thyroid cartilage invasion or trachea, esophagus, the parts which are close to the larynx. T4B is away from the larynx, like prevertebral space, mediastinum, etc. Stage T3 is T3 is stage 3, T4A is stage 4A, and T4B is stage 4B. Okay, this is correlating. This is correlating from stage T1 is stage 1, T2 is stage 2, T3 is stage 3, T4A is stage 4A, T4B is stage 4B. Now we are just adding one more component. N1 is stage 3, N2 is stage 4A, N3 is stage 4B. Okay, so that's what I have written here. T3 means stage 3, T4A means stage 4A, T4B means, but once it comes as N1, it is stage 3, N2 is stage 4A, N3 is stage 4B. Okay, so these 3 things you just remember. You can write down when in the exam, you can write stage 1, this is stage 1, stage 2, stage 3, stage 4A, this is stage 4B, stage 4C. So this is T1, write T1, T2, and you write any T, any with metastasis, M1. Now you write stage 3, stage 4A, stage 4B, and you can write any T here, any T, any M1. This is, that has got nothing to do with it. Okay. Now these 3 you can put N1, N2, N3. You will be right. right? N1, N2, N3, there is no N here. There is any T, any N with M1 is 4C. So like this, you can remember the staging. This is not going to go into your head in the first attempt. So you have to just think about it, talk about it. If you can explain it to somebody or record it in your mobile and re-listen to it also, it may help you. So with this, we come to the end of staging of carcinoma larynx. This staging applies for supraglottis, glottis and subglottis, for all of them. If you can get this on paper, you will get your marks. Thank you.